Well, I want to start by thanking Runcie for the invitation to join you all. I'm so privileged to be here with you today. And I'm just going to spend a few minutes talking about some of the advances in genetics. And it's wonderful to be able to join this distinguished group of speakers. So I'm going to start by saying we've all known for a long time about this familial link with cancer, right? So this is nothing new. And this is a picture from the early 1900s when there was starting to be some interest in, let's kind of plot out what that looks like. And then you know that in the 1990s, that was the time when we actually identified which genes were responsible for that passage of that risk from mother to daughter, or even father to daughter or father to son. So we identified these genes, and I would say over the next 10 years after the 1990s, we actually identified that the way to reduce that risk primarily was through surgical prevention. So we identified that actually, and this is kind of good news and bad news, that if you did a prophylactic mastectomy, that decreased almost to 100% your risk for breast cancer, and the same thing with the ovaries and the fallopian tubes. But really, there's been a revolution in hereditary cancer testing just in the last 20 years. In the same way there's been all of these new drugs, there's also been a revolution in hereditary cancer testing. And so remember in the early 1900s, that's when people first started identifying this. And then in the 1990s, there was identification of multiple genes, not just BRCA1 and BRCA2, but Lynch syndrome genes that accounted for colon cancer, other cancers. And then I would say in the last 10 years, the big game changer has been that before the identification of these genes was important to prevent cancer, all of a sudden it became important to know that information because it would help with the treatment if you had cancer. So not just for your daughters and your nieces and your sisters, all of a sudden it became important to you as an ovarian cancer patient to know what your BRCA mutation status was. So Dr. Matalonis is going to talk more about these emerging treatments. I'm going to just mention that in my talk. So I'm going to talk about three things. I'm going to talk about the convergence of therapy and prevention. I'm going to talk about emergence of something called moderate penetrant genes, which is a little bit confusing, and I just want to make sure that we mention it in case that someone kind of is told that they have a moderate penetrant gene. And then just talk at the end about an interesting study that we've been doing. So Game Changer 1 has really been targeted therapy, and Dr. Sood mentioned this. So these are two studies that came out that really all of a sudden drove us to realize that if you had ovarian cancer and we knew that you had either a BRCA mutation or if you had Lynch syndrome, which is another set of genes that predisposes to ovarian, uterine, and colon cancer, that we had very specific drugs that would be particularly effective for you. And so this is just a slide that I borrowed from my colleague that showed a whole bunch of trials that have come out tomorrow. Look in the news because there will be another set of trials that will come out that will also be talking about this. But we've had this emergence of FDA-approved drugs in this setting. So all of a sudden we want to know, does someone with ovarian cancer have a BRCA mutation? So think about the last slide, or one of the last slides that Dr. Sood talked about. There are states for which individuals with ovarian cancer have not undergone genetic testing. So think about kind of the loss of opportunity for treating them with these drugs. So we still have a ways to go to be able to get this right. There are going to be studies that have come out and that will come out soon that talk about most of you in the room will not have a BRCA mutation if you have ovarian cancer. So we think that only about 15% of patients with ovarian cancer have a mutation in BRCA1 or BRCA2. So that means that the majority of women with ovarian cancer do not. So then it's kind of like, well, gosh, I wish I had this on the one hand to be able to take advantage of it. Well, it turns out there are studies now that show that there is benefit. It may not be quite as strong a benefit, but there is a benefit. And so now those kind of next wave of studies are coming out to talk about individuals who don't have BRCA mutations. And one of the things that we realized is that family history is not a good predictor of BRCA mutation status in ovarian cancer patients. So I've spent a lot of my career looking at BRCA and ovarian cancer, but we would see people that we would test and we would look at their family history and say, gosh, you don't have any family history. And this was just a study that we did, and I'm not going to spend too much time talking about it, but basically what it showed is that in individuals who don't have a lot of family members or for some reason maybe don't have a lot of women in their family, they're not particularly useful to look at family history. And so what we decided is we're going to actually test everybody. And so these were some guidelines from our national societies that said, if you have ovarian cancer or if you have triple negative breast cancer, everybody should be tested. And that's where we are today. So this kind of came out a couple years ago, but that's where we are today. So every single ovarian cancer patient with epithelial ovarian cancer, there's some different subtypes, should have genetic testing. And I'm going to skip that. So what does that mean? So what that means to me when I see ovarian cancer patients is that, wow, we actually have new drugs that we can treat you with. What it also means is that we can actually test your relatives and help them prevent the disease, ovarian cancer and breast cancer. So to me, it's kind of this convergence of treatment and prevention. And one of our biggest challenges, so we have two big challenges. One is making sure every ovarian cancer patient gets tested. Our other challenge is how do we get the family members of those individuals who test positive, how do we get them tested? And that's kind of that concept of cascade testing, where you've identified a BRCA mutation, but wouldn't you like all of your nieces and your cousins and your sisters to be tested as well? And that's been an ongoing challenge. It's not an easy, there's lots of barriers to that. And so you can see that if this is a family tree and you have identified a BRCA1 mutation in an ovarian cancer patient, look at all the women who either have a 50% if they're a first degree relative or a 25% chance of having that mutation. And you know what's powerful? It's powerful to be tested positive, but it's actually very powerful to be tested negative. So if you're a sister of an ovarian cancer patient and you're like, wow, I bet my risk is increased. If your relative with ovarian cancer has tested positive and you test negative, we call that a true negative. That means your risk for ovarian cancer goes back down to the general population risk. And you don't need to remove your ovaries kind of at an early age, and two, you don't need to worry. So kind of that true negative result is powerful as well. So the other kind of game changer that's happened recently is the incredibly low cost of doing sequencing. So for many years in my career, it was about $4,000 to be tested for BRCA1 and BRCA2. That is very cost prohibitive for a lot of people. And before, insurance didn't cover it. Well, it turns out, and I don't think I may not have included this slide, but it turns out now it's pennies to do sequencing. And so now for about $200, you can test between 15 to 30 genes. So the cost has come dramatically down, and that's really made a difference. I'm going to kind of jump ahead and kind of talk about some of the implications. This was a very important study that looked at ovarian cancer, a large number of ovarian cancer patients, and they tested for more than just BRCA1 and BRCA2. And it turns out there's a whole laundry list of what we call moderate penetrant genes that are associated with ovarian cancer, but very rarely. So BRCA1 and BRCA2 accounts for the majority of them, and all these other genes probably account for maybe another 5%. So they're pretty, they're much less common, and they're all part of this pathway that is associated with BRCA. So what do we need to know about this? Well, let's say that you have ovarian cancer and you are found to have one of these moderate penetrating genes, the first thing you're going to think about is, can I use those drugs? Are those drugs going to be effective for me? And we don't know that. So those are some of the things that we think that it does make sense that that's the case, and I would probably treat someone with it, but we don't know. The other thing is, what about your daughter? What about if she tests positive? What would you tell her? Does she need to have her ovaries out at an early age similar to BRCA, or can she wait? Is it a later age of onset? Those are things that we still don't know. The other question is, are there other cancers? So BRCA, we know it's associated with breast and ovarian cancer. We know Lynch syndrome is associated with ovarian, uterine, and colon cancer. Some of these new genes, we don't actually know kind of what are the other cancers that are associated with it. Just wanted to mention that there are national guidelines because this information is changing so quickly. So NCCN is kind of one of the major national guideline organizations, and they come out definitely every year and sometimes even more frequently to kind of guide families and doctors about what to do with these moderate penetrant genes. And so, let's see, I'm going to kind of move towards the last part, which is just a study that we've been conducting, which will probably end soon, but I just wanted to let you all know about it in case you wanted to participate, because it's an opportunity for relatives of ovarian cancer patients, so potentially your sister and your daughters, to get testing for free. And it's only going to be open probably for another month or so, and so I just want to make sure I mentioned it. So we have a lot of barriers to genetic testing for family members, okay? So we know that all ovarian cancer patients should be tested. Actually, insurance covers it now, but what about your relatives? And there's all sorts of barriers. One, a lot of your relatives you don't speak to very often. Another barrier is that some of them may be living in areas that don't have access to genetic counseling or access to kind of good medical care. Sometimes there's kind of barriers within family in terms of communication, so it may be that you don't communicate broadly. And so we wanted to figure out how do we address these barriers. Oh, and this is the slide that I was looking for. So this is the cost of sequencing. To sequence DNA, this is in 2001. You can see kind of the cost. And now it's pennies. So this has really been a game changer in terms of the availability of testing. I'm going to stop for a minute and talk about commercial testing. Renzi and I talked about this last night. So you've heard about 23andMe or Ancestry. And what I would say is it's okay to do it, but it is not medical grade testing. Okay, so you can't do it for the purposes of knowing that you're at increased risk for cancer. You can do it for fun to kind of find out what your ancestry is, but it's definitely not medical grade testing. But medical grade testing is still available to you. So let's just talk about that. So lower cost of testing expands opportunities. We were just wondering, what if you could do genetic testing at home? You didn't have to go see a doctor. You didn't have to see a genetic counselor. You could actually use a spit kit and do it and send it in and get the results at home. So that's what we wanted to test. Is it feasible? Does it result in more distress because you're not having a face-to-face with a genetic counselor? Does it result in less knowledge? Would you do something kind of unfortunate, like having surgery that you didn't need if you didn't have it? And so we started this study, and if you want to either write down, it's magenta.mdanderson.org, or you can just Google Magenta and genetic testing or Magenta and MD Anderson. And basically this study is for individuals who don't have ovarian cancer, but who have a family member that has ovarian cancer. And it's really nice. You can watch the video. You sign all of the consent online. And then we ask you to fill out questionnaires. And the reason is because we want to figure out do you understand the basics of what the testing means? Is this going to cause you kind of undue distress? And so the goal is to compare this standard approach to genetic counseling, and now our standard approach is either in-person or telephone counseling, to these alternatives. And just wanted to let you know that this study's been open for about 2.5 years, and we've enrolled women in every state. And they don't have to go anywhere. They can do it at home, and it's been really a fun thing to lead. And we've had 6,200 women actually go to the website, and about 4,000 have signed consent. And you can kind of just follow about 2,600 have gotten their test results. But what we're trying to say is this a reasonable option for family members who may not be able to kind of talk to their gynecologist, or maybe their gynecologist says, ooh, I've heard of that, but I'm not really sure. We want to make it easier for women to do this. And I'm just going to end by saying that organizations like OVARCOMING, organizations like the NOCC, this is a Minnesota Ovarian Cancer Coalition, they've helped us recruit women almost purely through social media. And so I'm not someone who was ever inclined to social media, but now I really understand the power of it. It's been really remarkable. And this is, I'm just going to end with this patient perspective. We got this in an email box. We had a magenta email, and so I'm going to read it to you. It says, in June of 2006, I lost my mother to ovarian cancer. At the time, there was little known about the BRCA gene, and my doctors did not encourage testing. Even as more evidence came out about the BRCA gene, I thought it wouldn't be me. My mom was the only person with cancer in our family. I've worked in the cancer world for more than 10 years and always thought it wouldn't be me. I remember thinking I should do this, as I should know the process and encourage others to do it. So I signed up, and within 2.5 months, I found out that I do have a mutation in the BRCA2 gene. Shock, fear, denial, just a few feelings I went through. If it wasn't for all the signs that I needed to be tested and the ease of testing through the Magenta study, I probably wouldn't be tested. Now that I've processed this information, I could consider myself lucky as I know my risks, I'm young, and I have a wonderful hospital nearby. So this was a very gratifying thing to really realize that it can really impact others. So I guess I'll end by saying that I'm going to really share Dr. Sood's thoughts that there's a lot of hope, both in terms of treatment and prevention. We are all looking to the future because we really believe that there are going to be advances not only to treat ovarian cancer, but also to prevent the disease. And so I'm going to end there. Thank you very much.